Record before I forget to record. Great. All right. Welcome everyone to our fourth intern teaching conference. This is the first intern teaching conference of this second block. So welcome to those folks who have transitioned onto an inpatient service, and welcome to the Good Life for those who are on immersion block. And this actually marks halfway point through our intern teaching conference this summer. So time is flying. We are incredibly lucky to have Dr. Susan Merel join us again this year. Dr. Merel is a hospitalist, a geriatrician, and palliative care provider, and one of our fantastic clinician educators who is based at UWMC. The Montlake campus also does palliative care consults at Harborview. She also runs the sub-I for UW School of Medicine. Susan is going to be talking about an approach to pain in inpatients. And I'm going to let Susan take it away in 1 second. As more folks are joining, I'm just going to remind you that if you have not yet scanned the QR code, for attendance, I will include it at the end of our presentation this morning, along with a link for the evaluation. And then finally, there will be a different link for ITC, a different Zoom link for ITC next week, just next week. We will send that out ahead of time. Okay. And Dr. Merel, take it away. Oh, can't hear you, Susan.
You'd think I'd never do that, but it still happens now after years of Zooming. Yeah. Welcome, interns. So good to see you. I'm actually on service at Harborview this week on palliative care, so perhaps some of you will consult me. I'm on this week and next week. Hopefully I'll see some of you. I'm going to talk about management of pain in the inpatient setting. Here's my disclosure slide. Nobody pays me extra to take care of patients with pain and older adults. So you have probably had a call like this, and if it struck a little fear into your heart, that is totally normal. It's a big deal to give people opioids, and I'm hoping to demystify this and give you guys an approach. So the objectives of this talk are to describe an approach to pharmacologic pain management in hospitalized patients. There are non-pharmacologic things we can do that's kind of outside of the scope of this talk. Practicing opioid choice, titration, and conversion, recognizing and managing opioid side effects, managing opioid withdrawal in hospitalized patients with opioid use disorder, and also talking a little bit about best practices in pain management in folks on comfort care or hospice care in the hospital. I am not talking about the elephant that's always in the room when we are using opioids, which is chronic use of opioids for chronic non-malignant pain. The medical system got itself in a pickle by greatly overprescribing opioids in the outpatient setting for things like chronic back pain. We have learned that that is not helpful to anybody. I worry sometimes that makes us too fearful to use opioids where they really should be used, which is people in acute, severe pain due to serious illness in the hospital and sometimes in the outpatient setting. All right, so we're going to launch right into cases. This is going to be case-based. The first patient is Mrs. S. She is having 10 out of 10 right hip pain. Tylenol, 500 milligrams every 6 hours as needed, is not working. You look at your trusty sign out. It says that she's a watcher. People have identified that bad things happen to older adults in the hospital. She had a right hip fracture. She's going to the OR in the morning to get that fixed. She has some CKD. There are her meds. She has been correctly identified as somebody at risk for delirium. So you go to see her. I'm not really supposed to say that older adults are cute, but sometimes they really are. She's cute. She is a little bit hypertensive. Her vitals are otherwise pretty normal. She's small and frail. She is not delirious. She is having pain. You do an exam. She has pulses. There's nothing new going on. There's no giant hematoma. The pain is from her hip fracture, and her creatinine is 1.3. So first poll question, Dr. Berger is going to put the poll question up. What are you going to do to improve her pain control? Are you going to add ibuprofen? Are you going to stop the Tylenol and change to a combination product like a Percocet or a Vicodin? Are you going to add oxycodone at that dose, or are you going to add IV morphine at that dose?
All right, we've got a lot of answers flooding in. I'm going to wait just a few more seconds. As always, I like to remind people, this is super low stakes. All of this is anonymous. Put your nickel down, commit to an answer. That's how we learn best. It's sort of the way that we wear those paths of memory deeper into our brain. Okay, so I'm going to call it here and share the results.
And that is the kind of results that I like. Somebody chose all of those choices, which means I didn't make the question too easy. I agree with the majority of you who did say that C is the best answer in this situation, but I'm going to talk through all of those. Thanks so much for participating, everybody. So Tylenol and or NSAIDs in the appropriate population can augment opioids. When we start opioids, we don't stop the Tylenol. And in fact, we usually schedule it, which is something that I would do in this patient. I do avoid NSAIDs for the most part in older adults because of the high risk of renal failure, CHF, and GI bleeding in this population. This is an official recommendation from the Journal of the American Geriatric Society, or from the American Geriatric Society, which I agree with and practice generally. In fact, I don't use NSAIDs a ton in inpatients because younger adults too are at risk for renal failure and bleeding. The times in which I would reach for NSAIDs in an inpatient population is usually a younger person with normal renal function who has a really inflammatory source of pain, or who happens to have some musculoskeletal thing that's usually incidental to the reason that they're being hospitalized. And sometimes near the end of life, when we might not be worried about renal function quite as much, NSAIDs are helpful for bony mets, as are steroids. But in this particular patient, I would avoid NSAIDs, so that's why I wouldn't choose the ibuprofen. The reason why I wouldn't choose the combination product is that in acutely ill patients, we should be prescribing the acetaminophen and the opioids separately so that we can titrate both components of that. I think of Percocet and Vicodin as helpful really mostly for something really self-limited in the outpatient setting, some big dental procedure that's going to be really painful for a couple of days, or some kind of fracture or something like that. In general, even in the outpatient setting, there's a risk of unintentional Tylenol overdose with combination products. So I use those with caution in general. So again, the best answer for her, I think, would be the oxycodone, scheduling the Tylenol and adding a low dose of as needed oxycodone, Q4 hours, hold for sedation. Why the oxycodone rather than the morphine? When I can use the gut in general for any medication in the hospital, I do. For a variety of reasons. In the case of opioids, the oral opioids last a lot longer. We prescribe IV morphine Dilaudid every couple of hours, but it really lasts half an hour or an hour. And so people have a much more even pain level if they can take oral. So again, C would be my best answer. Is it okay to give this frail older adult oxycodone. It is if you are careful. Yes, opioids can contribute to delirium, so can pain, right? And pain can keep people from getting out of bed and mobilizing and rehabbing. I do take a look at people's creatinine clearance when I give morphine because of the high prevalence of renal failure in this population. All right, moving right along. Say it's the next night, her surgery was delayed, the OR is really busy, it's the summer at Harborview. She is still having 8 out of 10 pain despite oxycodone, which she's taking the 5 milligram dose every 4 hours, and she's taking her scheduled Tylenol. She, on exam, still looks uncomfortable. She is not delirious. She says the oxycodone helps, but just a little. Do you start low and titrate up the added opioid? Question from Ruth. Yes, we're going to talk about that. That's what this question's about. That's a great question. So what order do you write to try to improve her pain control now? Do you A, add hydromorphone or Dilaudid? Do you B, increase oxycodone to 7.5 Q4 hours PRN? Do you change the oxycodone to 5 to 15 milligrams Q4 hours PRN, the range dose? Or do you schedule long-acting oxycodone or OxyContin?
Great. And as folks are putting their answers in the chat, just a quick reminder, if you do have questions, we do encourage people to make this interactive. So please do put questions in the chat. Either Dr. Merel will see them or I will make sure to catch them and bring them up if she does not.
Despite being old and not that good at Zoom, I can actually see my chat box right now.
I've seen you do that.
I'm proud of myself for doing that.
All right, everyone, I'm going to go ahead and end the poll and share the results.
Great. Again, somebody answered every answer, which is great. And the majority of you did answer the answer that I would choose, which is B, increase the oxycodone to 7.5 milligrams every 4 hours as needed. A lot of you did choose C, and I see that order a lot in the hospital, which is why I included. I don't think it's technically the best answer, and I'll talk about why. So there's only a couple of things that I think you should actually memorize, keep in your brain from this talk. The other things you can look up on the slide or write down and look up later. One thing that I do suggest remembering is that the amount of dose escalation for opioids should generally be between 25 and 100%. So something like a 25 to 50% increase for mild to moderate pain, a 50 to 100% increase for moderate to severe pain, not increasing less than 25% or more than 100%. So that is why the 5 to 15 milligram range is actually not a correct order. It doesn't get patients in trouble because the nurses generally wouldn't jump up that high, but it's still our responsibility as a prescribing clinician to write an order that's going to be technically correct all the time. In terms of increasing less than 25%, that happens more often, like if anyone on this call is on the hem-onc service and you have somebody who's on 50 milligrams of morphine due to severe pain, and they're quite opioid tolerant, you might think, oh gosh, that's so much. I'm going to give 55 or 60. But really, that's just actually not going to make a difference. And you need to give a good 25% increase or use some other method of pain control than what they're doing. Somebody asked dosing change if they have a concern for long QT. In the low doses, so that is mostly an issue for methadone, and is a little bit out of the scope of this, but at the low doses we usually use in the hospital, not a huge deal, but mostly an issue for methadone, so not an issue with oxycodone. Sorry, was there another question? You can increase short-acting oral opioids every couple of hours if you have somebody where you particularly need to find them a stable dose of oral opioids without relying on a lot of IV for breakthrough. You can actually come back in a couple of hours and make the next dose higher. You shouldn't increase long-acting oral opioids more often than Q24 hours, like Oxycontin, MS Contin, and you shouldn't increase a fentanyl patch more often than every 72 hours. So what about those long-acting opioids? I put Oxycontin as a choice on there. So scheduled pain medication is often appropriate for constant severe pain. Oxycodone, Q4 hours, scheduled, hold for sedation. But don't start long-acting opioids unless the pain is relatively well controlled. And for somebody who's going to be leaving the hospital soon, you need to confirm that this is somebody's appropriate to be taking long-acting opioids for a period of time at home, and has somebody who will prescribe them or some way to taper them down, because people will go into opioid withdrawal and that's uncomfortable for them. So again, scheduling short-acting opioids with a hold for sedation order is a good option. And again, the B is my preferred answer. All right. Poor Mrs. S had her surgery delayed. It's really going to happen now. This is a little bit of an artificial situation, but let's say that she is strictly NPO and she needs something IV, and oxycodone does not come in IV. So at this point, her pain has been relatively well controlled on oxycodone, 7.5 milligrams every 4 hours as needed. You decide to stop the oxycodone and start IV hydromorphone. So what do you do to transition somebody from one opioid to another? Luckily, you don't need to start over from the lowest possible dose. So what you do is start with the total opioid use in the past 24 hours. You pull up your medication history in Epic, and you look at what did they get in the past 24 hours. You use an opioid conversion chart or website or app. The one I like that I have on my phone is that one with I think that's a morphine molecule there. It's free and it's a easy to use app. So you put in your amount that they got in oxycodone. You click on something that says, I want to transition this patient to hydromorphone. This app and most of the websites that you will use will remind you to decrease the equa-analgesic dose by 30% to account for incomplete cross tolerance. So if you've been taking oxycodone for a couple of days, your opioid receptors are going to be pretty used to it. And so you spent a day feeling a little bit nauseous, a little bit tired. And if we give a lower dose the next time, the patient won't really have to go through the side effects again. You then divide up that 24-hour dose. And if you're doing this for the first time, or the patient's on high doses, or it's a medication you haven't used before, this is the time to ask for help. Just as a reminder, we used to use these tables all the time. Now it's a little bit obscured by a computer algorithm. So some people like to look at it kind of in this graphic form. I think another takeaway here is that when you are transitioning to IV hydromorphone from pretty much anything else, you will come up with a small number. IV hydromorphone is potent. It doesn't mean it's unsafe or that you shouldn't use it, it's just potent. So is fentanyl, but because that's dosed in micrograms, often that's pretty obvious to people. Oh yeah, that must be something really potent because they're giving a really small amount. Slide number 2 that you might consider storing in your head rather than in your phone or in your pocket or on your computer, is that a milligram of IV morphine is roughly equivalent to 3 milligrams of oral morphine, 2 milligrams of oral oxycodone, or 0.2 milligrams of IV hydromorphone. So again, that's a pretty potent medication. Won't belabor the math, but if you were going to do the math on paper, this would be how you would do it, and you would end up with 2.4 milligrams of IV hydromorphone for 24 hours, and you would divide it up usually every 2 hours as needed. A PCA might be a good option here, which I'll talk about in a minute. All right, moving right along to a new patient. This is Mr. G. He's an unfortunate 73-year-old gentleman with metastatic prostate cancer. He is on hormonal therapy. He's had radiation therapy to his spine. He was admitted with worsening pain, somnolence, and new renal failure with his creatinine at 3 from his baseline. And he's been taking morphine, Tylenol, and Senna. A little bit more information about him. He's been taking long-acting morphine at home, 60 milligrams every 12 hours, and then some breakthrough that he's taking a couple of times a day. He has more pain and is more somnolent over the past few days. When you go to see him, he's hemodynamically stable, but he's pretty sleepy. So I didn't make you guys answer a question this time. I may have made it relatively obvious. He could be somnolent for a number of reasons, but the reason I'm highlighting here is that his morphine is building up in his renal failure, and it's making him more sleepy. So
Susan,
the question is, yes.
Sorry, just before you move on, there's a question in the chat about whether there are calculators in Epic that help with the opioid conversion. And before we get too far away from that topic, I thought it might be helpful to address that.
Yeah, I don't actually know. Is there an opioid calculator in Epic?
I'm not aware of one.
Yeah.
I've never seen one in Epic or been told about it. Although I will say, I think there are like deep recesses of Epic that many of us have not explored. So if anybody in the in ITC, if any of the interns here this morning are aware of that, please throw that in the chat. But I am not. I usually use online calculators. But to that point, I always use, I almost always use an online calculator. This is not math that I do in my head for opioid dose conversion, because it is really important that you make sure that you get that dose correct.
Yes, and the only reason why I'm suggesting that you remember the relative potencies of a couple of things is just to kind of double and triple check. Oh, gee, IV hydromorphone came out, and it's a really small number. That makes sense to me. But yes, I use that app on my phone. I heard a long time ago that CPRS had a opioid converter. I don't actually know that for sure either. So going back to opioids and renal insufficiency, methadone and fentanyl are actually the textbook optimal opioids in renal insufficiency. That is a little bit of a bummer because methadone is really long acting and not helpful in acute pain, and fentanyl only comes in short acting and in a long acting patch and in a lollipop, which costs $10 and just got taken off our formulary. Luckily, hydromorphone and oxycodone are totally appropriate in renal insufficiency, and those are the agents that I reach for. Hydromorphone is preferred to oxycodone in dialysis patients. I avoid long-acting oxycodone and morphine in people with significant renal insufficiency. So again, go-tos in renal insufficiency are generally hydromorphone and oxycodone, hydromorphone in dialysis patients. in liver failure, again, fentanyl is the textbook thing, and sometimes we do use fentanyl, but hydromorphone and oxycodone are also totally reasonable to use in liver failure. Again, at avoiding morphine and long-acting oxycodone, and generally avoiding methadone in liver failure, although it can be used generally by experts. This is my summary. So avoiding both morphine and long-acting oxycodone in both liver and kidney failure, avoiding methadone in liver failure. Fentanyl is optimal in both, but what we generally use is hydromorphone and oxycodone with a little bit of an extended dose interval, maybe starting at Q6, especially in somebody who's pretty ill, and then titrating it up as you needed, and using hydromorphone or Dilaudid in dialysis patients. I'm going to just pause there and look at the chat. All right. Couple of more words on opioid choice. I'm not saying don't use morphine. It's a good first-line agent if there is no renal or liver failure. It comes in multiple formulations. It comes in IV, it comes in pills, it comes in long-acting, it comes in liquid formulation, it comes in sublingual. It's also really cost-effective for patients, depending on people's insurance. Sometimes oxycodone can actually be shockingly expensive. So people can take morphine. It is totally reasonable to start with that. I don't prescribe codeine. It makes people throw up and doesn't help with their pain that much. I avoid meperidine or Demerol. It lowers the seizure threshold. It can be more deliriogenic. If you are on the hem-onc service, you may see it being prescribed occasionally for Rigers. There is a theoretical benefit over other opioids. From the evidence that I've looked at, morphine would probably work too, but if an oncologist asks you to try a little bit of Demerol, I would honestly probably go with it. They've been using that for years and it's okay. But other than for Rigers, I wouldn't do it. And I wouldn't use Demerol in renal failure. And then Tramadol has a place in the outpatient setting, but in the inpatient setting for acute pain, I don't find it safer or all that effective. So those are some agents that I don't really use. So back to the case, again, morphine is accumulating in renal failure. Again, he was on long-acting and short-acting morphine and comes in with renal failure and quite sleepy. What would you do? If he wakes up and has pain, I would give him some IV Dilaudid. When he wakes up enough to take pills or liquid, I might give him oxycodone or hydromorphone. I also might think about a fentanyl PCA, which would require a consult to palliative care chronic pain, but it might be a really good option to him. In terms of what could he be sent home on, he could be sent home on oxycodone or hydromorphone oral or on a fentanyl patch. This is a suggested protocol for malignant pain. A seriously ill patient, usually somebody with cancer, where you know that it's going to be appropriate for them to have opioids for a longer term time because their cancer is not going to go away and they're going to still have pain. So I would start scheduled short-acting opioid at every 3 to 6 hours, depending on what works for that patient, with a hold for sedation order. I would order some breakthrough, 10% of their 24-hour dose. So if their 24-hour dose is 100 milligrams of oxycodone, they would get 10 as needed. Adjust the scheduled dose every 24 hours based on their use, based on their symptoms. If, say, a patient is sedated, if you ever need to de-escalate opioids, it's the same as the escalation for the most part. Decrease it by 25 to 50%. And then when the pain is controlled, then you convert to a long-acting pain medication like a MS-Contin, Oxycodone, fentanyl patch. All right, I'm looking at the chat for questions, and I don't see any, so I'm going to keep going. Oh, yeah. Does methadone work well for acute pain? So methadone has a little bit more efficacy in neuropathic pain than other opioids. So if there's a neuropathic component for somebody's, so I guess actually to step back, methadone would be for new pain that we expect to last for a long time. So not necessarily like acute in the pure sense. I don't come running with one dose of methadone for anybody, but if somebody has pain and is going to need longer term scheduled pain, we do sometimes use methadone. Yep, good question. So I've thrown around this idea of a PCA, a patient-controlled analgesia pump. So what the heck is that? And what do you guys need to know about it? So a PCA pump is a safe method of delivering a relatively constant, really low dose of opioids. It's appropriate for a patient who's alert enough to press a button where they otherwise would be appropriate for opioids. The pain is impacting their function. You don't know their 24-hour dose, or you need to titrate rapidly, because if somebody has a regimen at home that you can work from, you can often just do that. Oh, I can increase their oxycodone by 50%. You may not need a PCA. But when you really don't know where to start, and especially when somebody's really having a lot of pain. And then sometimes in patients who are having a lot of trouble with the idea of pressing the nurse call button, waiting for the nurse, they're just very uncomfortable and they get very, very anxious waiting for their pain medication, and they're otherwise appropriate for 24-hour opioids, then that would kind of lean me towards the PCA. Here's the elements of a PCA order. There's the dose that's called the lockout dose, or the incremental dose. It's the dose that you get when you press that button there. There's something that's called the Clinician Bolus. The clinician in this case is the nurse. You press the PCA button, and if you still have pain, you press your nurse call button, and the nurse can come and can give you a larger amount that they can give a couple of times over 4 hours. And then the last part of a PCA, which isn't present all the time, is a continuous infusion. So you're getting 0.5 of morphine when you press the button, but you're also getting 0.5 per hour, either 24 hours a day or just at night. In our system, only the pain service or palliative care can write an order with a continuous infusion. But don't be scared of that. It's usually like not a very long process to get somebody to put a continuous infusion on, or if your patient comes in on a basal opioid, they come in on methadone or MS-Contin, you need pain service approval to continue that. And again, not a super long process. So the PCA that you guys can order, the primary service PCA order set is a low dose of hydromorphone or morphine without a continuous infusion. And I talked already about patients in which you might consider ordering this. Again, if they're on home basal opioids, or a continuous infusion, then you do need a consult for that. Don't forget about the clinician bolus. So if the nurse calls you and says your patient on a PCA is having a lot of pain, your first question should be, have they gotten their clinician boluses? Because usually the nurses will go ahead and give that, but they won't always do it, or they won't always do the full amount. If a patient is on opioids at home, make sure when you start a PCA that you compare what they could get with a primary service PCA to the equa-analgesic dose of what they were getting at home, to make sure that you will be able to give them something that is equal to or greater than what they were getting at home. Otherwise, you would want to consult palliative care or the pain service. And the order set includes the option of giving folks a number of medications for symptoms, Benadryl, and a number of antiemetics. And for the most part, I uncheck anything that is sedating when I put somebody on a PCA, so that I know if they get sleepy, is it from the PCA or is it from their Benadryl or their Phenergan? Any questions about PCAs? I'm going to pause and watch the chat here. All right.
I'm just going to make a quick comment, a quick plug, Susan, for folks. When you have a patient on a PCA, strongly recommend that you ask the nurse to show you how to look in the PCA pump to see how much opioid the patient has used over the prior 24 hours. I think we're often very afraid to touch buttons on pumps, which in general is a good rule, but you're actually not typically going to mess anything up. And it's fairly straightforward and extremely helpful to have that information for yourself, for rounds, for you to know how to titrate. So just ask the nurse to show you, you'll remember it from there.
Yeah, that's a great point. And I have to say that with the transition to Epic, I think we are still catching on as a system in how to record PCAs. I have found it to be a little bit honestly, less reliable in general than the old way that it was recorded in our old charts. That's even another reason to just look at it yourself. Yep, that's great. Okay, new patient. This is Mr. M. He is a 50-year-old gentleman. He was admitted last night with endocarditis, and he's agitated and he's having a lot of pain, and he's asking for methadone. So on your trusty sign out, he's a watcher. He's only been here 2 days. He has a history of opioid use disorder, and he's here for presumed endocarditis. He's on vancomycin and Tylenol. So the first question is, or the first point is to have a sense of what to look for your patient in opioid withdrawal. What are the signs and symptoms, which I have up there. The time course for somebody who is using IV heroin outside of the hospital is 36 to 72 hours is when the withdrawal would peak. It lasts kind of a long time for methadone because it is so long acting. It peaks later and it can last a couple of weeks. What you want to know from a patient with opioid use disorder who's in the hospital is their use of any other drugs, their history of any medication-assisted therapy for opioid use disorder, like with methadone or Suboxone, and their wishes regarding medication-assisted therapy during the hospitalization. So again, this is not a patient who gets 80 milligrams of methadone at Evergreen Treatment Services and goes there every day and picks it up. This is somebody who is using IV heroin and maybe other opioids on the street. It's much more straightforward if they're using methadone prescribed by a physician, and you can just verify that dose and give it to them. But this guy is not using medication-assisted therapy. You think he's in withdrawal. He says every time I come to the hospital, I get 80 milligrams of methadone, but you can't verify that. So what order would you write? Would you give 80 milligrams of methadone, hold for sedation? Would you give 20 milligrams of methadone, hold for sedation? Would you give oxycodone as needed for withdrawal symptoms? Or would you avoid opioids altogether and give clonidine, hydroxyzine, and Phenergan for withdrawal symptoms?
All right, I can see the wheels turning in people's brains as the votes are rolling in. Okay, I'm going to give this just a couple more seconds and then I'll share the results. But note that fewer people are voting, so harder question.
Okay, somebody picked every answer. So again, that's great. And a majority of you did pick the answer that I would pick, which is methadone 20 milligrams daily, hold for sedation. And I'm going to talk about why. So the goal of treatment of opioid use disorder in inpatients is to prevent or treat acute opioid withdrawal in order to allow optimal medical care. It sounds kind of silly when you say it out loud, but I think sometimes we think that, oh gosh, this person has such a terrible problem with opioids. I don't feel comfortable giving them more. It could make the opioid use disorder worse. I should withhold opioids. Maybe it'll kind of make it better. But really, they have a long-term, chronic, difficult to treat medical problem. And what we do, if just giving opioids during an acute hospitalization is not really going to impact their opioid use disorder overall, what's going to happen if we don't give people any helpful treatment for their withdrawal is often they'll leave the hospital and not get their medical problem treated. We should always initiate substance use treatment referral if the patient is open to it. We should make sure that they have naloxone. There is a great monograph in Occam from Jared Klein. He's one of our opioid use disorder experts. And I do recommend taking a look at that. I'm not clear on the question about the hospital standard taper. I am going to talk about the standard dosing for methadone. And if you still have a question, Ruth, you can ask it in the chat or at the end. So in my mind, the standard dose of methadone for treatment of opioid withdrawal in inpatients is starting with 20 milligrams PO daily, going back within a couple of hours to assess for folks' symptoms and giving an additional 5 or 10 milligrams of methadone within that time, but generally not giving more than 30 on day one. Every 72 hours or so, you can increase by 5 to 10 milligrams. We don't generally give more than 40 milligrams a day in inpatients. And if somebody is having acute pain on top of their opioid withdrawal, then I do give them short-acting opioids in general. So why would somebody be on 80 milligrams or 100 milligrams of methadone as an outpatient, and I'm only saying you should give them 40 milligrams in the hospital? It's because the goal is different. The goal of opioid use disorder treatment in the community is for people to have their cravings knocked out, because it's theoretically easier to get heroin when you're out in the world. The goal in the hospital is for people to not have withdrawal symptoms. And we're also a little bit more worried about sedation in the inpatient setting. In So addressing Lindsay's question, that sounds state specific, if that is indeed a law. It's an unfortunate law because methadone is really effective for opioid use disorder and is really safe when it's used appropriately. So that is not a law here, and I'm glad it's not. And Ruth, I think your other question, so protecting nurses in general, and I assume you mean protecting nurses from patients who could become angry or even physically abusive if somebody feels like their pain or the withdrawal isn't being treated seriously enough. I don't think that necessarily a standard protocol is the only answer for that. That's a team approach between you and them and your attending and the hospital to not tolerate any kind of abuse from a patient towards a nurse or anybody else. And I've had patients kicked out of the hospital by security because they weren't treating nurses or me correctly, and that's sometimes around opioids and sometimes around other things. But this, I'm probably getting a little bit off topic for this talk, so maybe something we should talk about another time. All right, so 20 milligrams a day, hold for sedation is the order that I would write. Suboxone, buprenorphine, naloxone is also a good option. I don't reach for it first because to give somebody Suboxone safely, they need to be in really active withdrawal. You need to be monitoring their withdrawal and be sure they're really withdrawing so that you won't tip them into withdrawal. And I think that's hard for a lot of patients. It also is a little bit harder to treat people's acute pain on top of the Suboxone. So I don't reach for that all the time. You guys will be getting more training around that. Just a reminder that methadone has a lot of drug interactions. I don't expect you to have those memorized, but it is helpful to say, aha, methadone, I should talk to a pharmacist. There could be a lot of drug interactions. Methadone, or rifampin, some antiretrovirals, some antiepileptics can precipitate withdrawal. Some antifungals and antibiotics can increase the methadone level and cause somnolence. All right. Mrs. D is a patient with new 6 out of 10 suprapubic pain. Morphine and Tylenol are not helping. So you look at your sign out. She is stable. She is a patient with metastatic breast cancer to her brain and her bones. She was admitted for pain control and radiation therapy. She is getting increasing doses of morphine for pain. Her medications are morphine, prednisone, Tylenol, and Zofran. So what would you do next for her suprapubic pain in a patient getting significant morphine for cancer? Would you increase morphine by 25%? Would you increase morphine by 50%? Would you bladder scan her? Would you add ibuprofen? Let's say her renal function's good.
Great. And while we're waiting for votes to roll in, Susan, I'm just doing a 10-minute time check.
Yep.
All right, couple more seconds. And I'm going to go ahead and end the poll.
All right, that question was maybe too easy, which is good because we're running out of time. She is having urinary retention from morphine, and so she needs to be bladder scanned. So people generally remember that opioids can make you constipated, nauseous, confused. I think sometimes we forget that they can cause urinary retention. The treatment for that is Foley or straight cath. If you need to, you can decrease the opioids just a little bit, but often you can just put a Foley in and it'll get better over time. All right. Let's say that a couple of days later, the nurse calls to report that Mrs. D is really sleepy. She's getting hard to arouse. She is breathing, but her respiratory rate is really slow. It's 6. She is full code. The rest of her vitals are there. Her blood pressure is fine. She is breathing slow. 8 is low. Her oxygenation is fine. You go and you call your senior resident and you guys go together and the stat nurse is there and you shake her and she rouses just a little bit. So what do you do next? You give 0.4 of Narcan, Naloxone, give 0.04 of Naloxone, or you start a drip.
Nice. Oh, I like the speed with which these answers are rolling in. Okay, awesome. A few more seconds. Nice. All right, here we go.
Okay, and not surprisingly, it's evenly split between 0.4 and 0.04. All right, I'm gonna go ahead. So about Naloxone, in a resting patient, a respiratory rate of 8 to 10 is usually okay, especially if the goal of care is comfort, but 8 for a long time, 6 is too low, and you probably do want to give a little bit of Narcan. You want to be careful because Narcan can precipitate withdrawal and pain. It can make people really uncomfortable. I go with a really low dose. I have the nurse dilute the 0.4 amp in 10 mLs of saline and give a milliliter. So 0.04 Q5 minutes with all of us standing there. If it's emergent, if you're really worried about somebody's airway, you can give a little higher dose, like 0.1 or 0.2. All right. Last poll question. So Mr. G, 10 days later, he's a 73-year-old gentleman with metastatic prostate cancer. He is on comfort care. He is going home with hospice. He was getting as needed hydromorphone boluses for pain, but he just lost his IV. He's having pain now. He's somnolent but arousable. The nurse is worried about whether he can swallow pills, so she doesn't think that dilaudid pills is a good idea. So would you place a central line and start a dilaudid drip? Would you order a PIC and start a fentanyl PCA? Would you place a fentanyl patch? Or would you start liquid hydromorphone?
All right, keep those answers rolling in. Give it another 10 seconds. Remember, commit. You will learn more when you commit. We all do. Okay, here we go.
All right. Split between fentanyl patch and liquid hydromorphone. Fentanyl patch is not unreasonable, but the way I've set up this scenario, it would be hard to know exactly what to start him on. And also, just the fentanyl patch isn't going to help him right now, right? Because a fentanyl patch takes about a day to really kick in. So that's why I would start him on scheduled liquid hydromorphone. The teaching point here is that we have a lot of options when our patients can't swallow pills. So IV, of course, is one option. Liquid oral opioids is also a good option that I feel like people don't know about enough outside of hospice. So liquid opioids have buccal absorption. So you do need to swallow it, but you also absorb some when it's in your mouth. And then also both morphine and hydromorphone come in a concentrated version, 20 milligrams per ml. So they're not having to swallow a lot. In hospice, routinely, family members squirt just a little bit of liquid morphine into somebody's mouth, even if they're not swallowing great. So liquid oral hydromorphone or morphine is something to just be familiar with. And if people need other symptom management, there's options for those too that are not pills. So that's what I would pick for this patient. In general, in a patient who's on comfort care or hospice care in the hospital, please use the standard order set. A lot has gone into that order set with pharmacists and nurses and palliative care doctors. First line for most patients should be liquid oral opioids. We used to just kind of automatically put people on a morphine drip, but it's just really not necessary for people to be hooked up to something near the end of life in a lot of cases. Opioids are first line treatment for both pain and dyspnea. If somebody has refractory pain, then I would transition to IV or a drip. Benzodiazepines are helpful adjuncts in comfort care for anxiety and insomnia, and the second thing that I would try after opioids for dyspnea and pain. All right, that was kind of a whirlwind. So I'm not expecting you to remember all of it. I do want you to always feel like you can call for help really anytime, but especially when a patient is in pain, and especially when you are using opioids. Call your senior resident, call your pharmacist, call the pain service, call the palliative care service, call a friend. There are no badges for going it alone. That's my email if you have further questions, and a whole bunch of people have made commentary on this talk over the years.
Thank you so much, Susan. We so appreciate your time. I see a couple questions in the chat that we'll address in just a second. Susan, they're above my attendance and survey links. Please take a minute, do your attendance link if you have not yet scanned the QR code at the beginning of the conference, and please take a moment to fill out our survey. Again, we use these surveys, your feedback, to inform our invitations and our talks every year, and to hopefully continue to make this a high yield conference for folks who come after you. So please do your evaluations. Thanks.
Yeah, so Rigo's question, liquid and pill forms. I don't know the technical answer for that. Anecdotally, one reason I sometimes reach for liquid oral opioids is I think they work a little faster than the pills. Again, especially if people can kind of swish them around in their mouth a little bit before they swallow them. So the dosing is the same, but I think that the liquid version sometimes acts a little faster. Some people just hate swallowing liquids. They'd rather just swallow a pill. And I don't think it tastes very good. I haven't tasted it. So it's not for everybody, but it is helpful. And then can you get liquid oral opioids inpatient? Yes, you can. And liquid morphine is pretty available at outpatient pharmacies as well. I've had trouble sometimes with liquid hydromorphone, people getting it community pharmacies, but our discharge pharmacies have it. That's a good question too.
And I'm going to jump in on a comment that Lindsay made earlier about discharging patients to methadone clinic. So to be really clear, and Susan can weigh in on this as well, we as inpatient doctors can prescribe methadone daily for medication-assisted therapy. We cannot discharge patients typically on medication-assisted therapy. There are some caveats there where sometimes we can bridge patients, but it is not the typical. So when we have somebody, if you are starting somebody or you are giving them medication-assisted therapy, methadone daily in the hospital, really, we all have to think very carefully about how they are going to continue that in the outpatient setting. And usually that is, it does require setting up an appointment at one of our outpatient methadone clinics for them to get an intake appointment quickly after discharge.
Yes, thanks for doing that. And the bridging situation is also possible and involves a doctor going to a remote part of the hospital and giving the methadone directly to the patient with the pharmacist right there. I've done it myself. It's not something that anybody wants to be doing for a long period of time. So people need to be getting into the clinic quickly.
Yeah. And just to differentiate that though, from methadone that we use for chronic pain, I do discharge patients on methadone TID for pain that can be continued by a physician in the outpatient setting. That is always a point of confusion.
Yep.
And Lindsay, I don't think you confused some details. It is complicated. So I'm glad you asked the question.
It's confusing.
Yeah.
That was
It's
really
probably
good question,
different in
Lindsay.
every
Yeah.
state, you know? So, yep. Cool. Great. Thank you all. Really appreciate it. And we'll see you next time. Susan, I'm going to stop recording. Thanks so much for your time as always.
All right.